Hi, I'd like to welcome everyone to our webinar today. This is a co-sponsored webinar with Greenwich Hospital and ONS. Today's topic, it's called Get a Grip, and we're here tonight, to really go over all the different types of common hand, wrist, and elbow problems also that cause difficulty with grip. I wanted to get started with just a few ground rules. I think I love an interactive audience, so if you are part of our audience today and you would like to ask a question, please do use the Q&A function at the bottom of your screen. If you can't find it, if you hover at the bottom of your screen, you'll be able to submit questions by text. And at the end of the session, I'll try to get to them. We're going to go through all your questions and review anything else that you might want to talk about. Secondly, please forgive me if you hear a baby in the background. That's my 1-year-old, and he just turned 1 yesterday, and he's kind of a loud individual, so hopefully you'll forgive me for that. Thirdly, I think that this is a pretty expansive topic, so feel free to submit other topics that you want to talk about, and I'll try to briefly get to them. And finally, I find it most helpful if these talks are a little bit condensed and allow you to really ask your questions at the end of the session. So my plan is to give a talk around 20 or 30 minutes and probably aim to have a lot of Q&A time at the end of the session to review some of your questions and take a dive deeper into some of your questions that you might have. So please feel free to get those prepared and submit them as you feel comfortable on the Q&A section of this webinar. So with that, we're right at 6:01, so I'd love to get started. So we're going to get this webinar going. Grip strength is an interesting topic for me as a hand surgeon because I think it is often a question that we get. Why is grip strength important, and how do I improve my grip strength? And I don't think I've seen many arms like what you see in this picture over here, but certainly I think a lot of people hope to get to this point. And while grip strength woes are sometimes overstated, I do think they actually do have a medical reason for why people are so profoundly kind of excited about this problem. Another question that I get beyond why is grip strength important is, should you buy one of these? And these are all over the internet. They're on Amazon. They're highly rated. You can see here that I did a quick search about what types of grip strength strengtheners are out there, and these reviews are amazing. 6,000 reviews for something that comes in a kit. You can get all these choices. You have a squeeze ball. You have something with a spring. You can activate each one of these fingers, and it's only 16 bucks. So, I often get questions from my patients, is this something I should get? Is it something that I should work on? And I'll give you the short answer in the beginning, but the short answer is you probably don't need this. And if anything, some of these products can cause more problems than be helpful. So something just to keep in mind. All right, so moving on here, grip strength, interestingly, is actually often used and can be thought of as a biomarker. What I mean by this is, if you look at this slide, there are actually so many things that grip strength can actually represent. So for example, grip strength has found in scientific studies, pretty rigorous scientific studies, to be a good representative, a marker of sorts for something like depression, nutritional status, bone mineral density, whether or not you're more more reliably to have a fracture or even a fall, general function, how active are you in terms of sports, and surprisingly, it's actually a fairly good predictor of mortality. So all of these things, including sleep and other comorbidities, are pretty interesting biomarkers, and I think grip strength is such a powerful almost a distillation of all these things that from just testing your grip strength, scientists have found that it can really predict many of these things. So that's something to keep in mind. We're not going to delve too much deeper into each of these topics, but I do want to get back to our main goal today, which is what really affects your grip strength. And grip strength, if we think about it, is involving all of your fingers, including your thumb, But what really catches people off guard is when you look at individual fingers and you think about which specific fingers really contribute the most to your grip strength. Many studies and most actually find that the ring and the small fingers are the ones that really give you 67%, maybe up to 80% of your grip strength. And these studies have been done in a very interesting way, meaning they test your grip strength with your fingers splinted. So it really takes it out of the equation. And they found essentially that your grip strength really is highly dictated by your ring and small finger. When you don't have those two fingers, your grip strength really goes down. If you wanted to select one finger that probably gives you the most grip strength or contributes the most, that would probably be the middle finger. So that's also something to think about. I think that some of these studies don't have too much of a clinical correlate, so we don't really worry too much about any of these one specific studies, but it's interesting to think that really it's the ring and small fingers that really contribute to the most of your grip strength. All right, so there's really 5 things I want to cover tonight. I think that there's enough time to go into them individually and really think about how you might diagnose, how you might treat, and maybe even how to prevent some of these problems. So here's our basic overview. There's 5 things. There's thumb CMC arthritis, which is the most common arthritis of the hand. The second topic will be trigger fingers, and there's so many different reasons for them, but I think it's a very simple but very common problem we should really talk about. There's tennis and golfer's elbow, and these are all problems up by the elbow, but they really relate to how you grip, because all those tendons that are partially responsible for tennis and golfer's elbow really go down to your hand. So tennis elbow can actually affect your grip strength. And those of you who have had it, I'm sure many of you on this webinar have had tennis elbow. You'll know that gripping is a major part of this. Fourthly, we're going to talk about carpal tunnel syndrome, and I want to group that together with ulnar neuropathy, which is very similar to carpal tunnel, but it involves a different nerve. So these two are going to be sort of grouped separately and thought of separately than the first 3, but we'll dive into those and kind of go through different treatment and also different ways to prevent these problems. All right, so to start, CMC basal joint thumb arthritis. So they're kind of interchangeable in our world. We call it CMC because it's carpal metacarpal. It's also known as the basal joint of the hand. So this relates to this specific joint down at the bottom here. And you'll see that in red. And what is really happening here is arthritis is when you wear down the cartilage. So when you wear down the cartilage, you develop pain because inflammation happens around that arthritic, that bone-on-bone kind of rubbing joint. Inflammation causes pain, and it's a real problem, and it's a real problem for so many people, and that's why it's such a common thing that we see. If you look at the statistics, almost 15% of anyone who's above 30 years old gets this problem. And if you break it down to postmenopausal women, you see that 1 in 3 actually have this problem. So it's more common in women, and unfortunately, it affects 1 out of 3 women. So it's very, very common, and it's a problem with gripping because you have to use that joint when you're gripping something. So this is what a typical x-ray looks like. I pulled this off the internet, but it's a very typical x-ray for those who have CMC arthritis. I don't know if you can see my cursor, but if you follow my cursor, I'm going to point to the area where this is bone on bone, and you can see there's a big difference between a normal joint, which is just below this bone, and what's above that bone. So there's such tight narrowing, the bones are literally sitting on top of each other, and that really causes the pain. So when you have no more smooth cartilage between these 2 bones, you develop arthritis, and arthritis develops inflammation, and inflammation hurts. So that's the typical sequence of arthritis, and it's a big problem with gripping. If you came to my office and you've never had any treatment of CMC arthritis before, the first thing we think about is how to make it better without any surgery. We think about non-operative treatment options. So I like both of these splints. These are the top 2 splints that I would suggest people wear. The one on the left is a very simple but very effective neoprene black soft sleeve that goes right around the thumb and also supports that joint. So there are many different manufacturers of something similar. What's important about this is it's comfortable and that it's somewhat supportive, but it's not too rigid. So people who have mild CMC arthritis, mild basal joint arthritis, they really feel comfortable in this because it just gives them enough support and it takes some of that pain away. if you need something more rigid, the next step up is really the picture you see on the right. And let me just go back. What you see here is a different type of splint. It's designed specifically for arthritis of that joint, but it's a little more rigid. So it gives you some more stability, and it does help a lot of people because it's so specifically designed for that joint. So it's something you can pick up on the internet. It's something that I think is effective. It's not surgery, and it works. Okay, so if you've tried your braces and they really don't work, or let's say you've tried them and they work for maybe a year or two and really it's not effective, the next thing we do is we give you a cortisone shot. And cortisone shots are tricky because I warn every patient I give a cortisone shot, it usually hurts for 3 or 4 days, maybe 5 days. So in order for the cortisone to really feel like it's worth it, I think that people have to have enough pain where if you do get this cortisone flare for 3 to 4 to 5 days, that it still seems worthwhile for you. If you only have pain every now and then and it's not so bad and you can tolerate it, I don't think a cortisone shot will be effective for you because you're probably not going to like the fact that it hurts so much. So, I think it's something to consider. It's very common to give these, but you have to just be careful about making sure you really need it. And you also have to be sure that if you don't get it from me, you have to be sure that you get it from somebody who gives them a lot. And the problem with those doctors that don't give them a lot, it's a very tough joint to get the cortisone into. So over time, it gets easier to learn how to do this, but you want to find somebody who is either a hand surgeon, like many hand surgeons at our practice, like my other two partners, or you want to be sure you have somebody that is experienced enough to make sure they get the cortisone in the right place. So something to consider and something really important to think about. If you are a candidate for surgery, there are so many different types of surgeries for this, but the real reason why surgery works is you're creating space. And that space is this area right below the bottom of that thumb metacarpal. So the part that is similar for every type of this surgery, you have to remove that arthritic bone. And that arthritic bone is rubbing on the next bone. So once you take it out, you have pain relief. And that pain relief really comes from just that space. The second thing that we do is we stabilize that joint. So once your bone is removed, and I know it's kind of it's a almost shocking thing to do, but once you remove that bone, you have good pain relief, but then you need to stabilize that area. And the reason that we stabilize it is we don't want this bone to rub or touch or cause more pain from all the other bones surrounding it. So there are different techniques of doing this. Sometimes we use a piece of a long tendon. Sometimes we borrow a tendon that's just right there. And in particular for me, the way that I've found most effective and probably gives you faster rehab is to not only use your own tendon, but to weave your tendon with a really strong suture that combines with your tendon and makes it a lot stronger. The tensile strength of this construct after surgery is very, very strong. It makes your rehab a little faster. So surgery is not for everyone and certainly not needed for everyone, but if you do need it, there's two things that are important. One is taking that bone out, which relieves that bone-on-bone arthritis, and the second is stabilizing your thumb. Okay, looks like people are trickling in, so that's great. I'm going to move on to our second topic, and that second topic is trigger fingers. Trigger fingers are really common. I think that many people, though, kind of confuse it with different types of problems, so I wanted to get into exactly what trigger fingers are. Here's a picture of a trigger finger, and this is the most common trigger finger. The ring finger is the most common. And what it really is, the way I like to think about it is it's a tendinitis, which means it's inflammation around your tendon. And every patient who has a trigger finger usually has inflammation right around your tendon. And that tendon is the one that bends your finger down. So if you have trigger finger, what's also tricky about this is although the problem is located where you see this nodule in the hand, a lot of people feel pain throughout the whole finger. So it might feel like pain at the knuckle that's a little bit further down. It might feel like some pain that travels all the way down to the palm. But the root cause of this is inflammation in the palm, and specifically inflammation right around this area here, which leads to some catching and clicking. And then if it gets really bad, it almost locks. So you'll have a lot of people who have trigger fingers they've ignored. And by the time they come in, their fingers are so tight and locked, they can't even get them open. So that becomes a real problem, but we'll talk about how we treat these in a moment. Risk factors for this problem for trigger fingers is probably related to repeated gripping. And again, I apologize if you hear my son out there making some noise. But trigger fingers are related to probably repeated gripping, so overuse. If you have diabetes, if you have rheumatoid arthritis, if you have carpal tunnel syndrome, these are also risk factors. So I think it's something to think about. You know, if you have a problem with your finger and you have something that is either related to diabetes or rheumatoid or carpal tunnel, it probably needs to be treated because it may not go away on its own. So the first treatment and the primary treatment for trigger fingers is an injection. Trigger finger injections can help relieve the problem and what I call cure the problem, because if you use cortisone, which is a strong anti-inflammatory, and the problem is really inflammation, it can literally cure it. It can make it better, and it can really take away the problem almost 80% of the time. So 80% of the time is pretty good odds that one injection is all you need. If it works and then it wears off, sometimes we do more. And usually the arbitrary number that we stop at is either 2 or 3 injections per finger. So that's also another common question I get, but there's a lot of mythology behind how many cortisone shots you can get. For this particular problem, really 2 or 3 is usually what we use. And the reason for that is if you deposit too much cortisone around a trigger finger, you can potentially weaken the tendon, and then you run into other issues like maybe a tendon rupture, which is really not ideal. Trigger finger surgery, if it comes down to it, and you might be indicated or eligible for this surgery if you've tried the shots, the cortisone shots, and it doesn't work. It's a simple surgery that relieves your pain because what we're doing is we're getting down to the location of the inflammation, and there's something called a pulley, which is a tight ring that holds your tendon in place that's too tight. And when the swollen tendon runs into that pulley, it really restricts your motion and causes pain. So this happens to be an area, this specific pulley, you don't need it. It really doesn't have any real function. So what we do is we make a small slit in that pulley, that ring, and we open it up. And that can be done in any finger, including your thumb. And once you make that slit, it creates more space for your tendon. And then you can move your fingers freely. And eventually, maybe 3 or 4 weeks later, you should still have maybe a little bit of pain, but it should be a whole lot better. So most patients, I say, if you are thinking about trigger finger surgery, it's an inflammation, it's an inflammatory problem. So although we're doing the surgery and we're getting rid of the root cause, it does still take time for it to get better. So I do think that, you know, it's not going to be a quick recovery, like within a day or two, but I would expect pain relief for around 3 or 4 weeks, and especially once the inflammation inside goes down. Okay. I'm going to check in to see if there's some questions that I can answer as we're going through this. Oh, a great question. So I'm going to try to tackle some of these questions as we go so we can address them. And I'll refer back to them at the end of the session to make sure that we answer all of them. But there is one question from Mark. Are you saying that a cortisone injection for wrist arthritis is more difficult than a cortisone injection elsewhere in the wrist, such as deeper veins? And I didn't include deeper veins in this talk, but it certainly is a very common tendon that gets tendonitis. And I do think it's harder. It's harder because cortisone injections into a joint, a deep joint like the CMC joint, it's a harder target. It's a little bit tighter. It's not quite as exposed or superficial as a cortisone injection for deeper veins, which is a different type of tendonitis. All right, so let me move on. We're going to talk next about tennis elbow. And tennis elbow, I want to go through some of these myths that we've maybe heard either on the internet or from friends. And I'm going to start with this one, which is tennis elbow is from tennis. And this is possible, but it's not really everyone. So this is the first myth that I think a lot of people hear about, but it's really not true. So tennis elbow is, though, very common among 40-year-olds, usually 40 to 60-year-olds. That's really the age which this starts to be a problem. It's secondly most common among 50-year-olds. And we often think of this as a rite of passage, meaning it's so common that it's very normal to have it. And it's something that happens and usually goes away. So this is how I typically explain it to patients, but it's something to think about because it normalizes this kind of pain. And also it's such a common disease. I think we almost think of it as a rite of passage. It's self-limited, meaning that if we were to do nothing, 99% of the time, it's going to go away. And I know many patients don't feel like this because it can be so painful and can last for quite a while. But from all the studies and all the things that we know about this problem, we know that most patients, it's just a self-limited course. So usually it goes away on its own. It's benign, it's not a malignant issue, it's a tendon problem. And I'll show you a few slides further on about this. And this is Roger Federer here, but it's not necessarily from tennis. So that's myth number one. So lateral epicondylitis is the other name of this. Lateral meaning it's on the outside of the elbow, and epicondylitis meaning it's that specific structure, and I'll show you in a moment what I mean. But the thought process and the theory behind this is when you have a susceptible individual, meaning somebody who's probably just going to get it, they have repetitive microtrauma, meaning maybe playing tennis, maybe raking leaves. It really could be anything repetitive involving your wrist or your elbow. And then you get this change called angiofibroblastic tendinosis. And it's kind of a fancy name for this process that we see on a microscope here. So if you take the tissue from that lateral epicondylitis from the elbow and you look at it with a microscope, you see these odd changes in the tendon. And the tendon changes are really what we think causes pain. So in this picture from the surgery, what you normally see in tendon is a nice, shiny, white kind of striation. And you can see a peak, you can kind of see that peeking through on the left side of this photo. But the rest of the tendon here is really unhealthy. It has this grayish, kind of friable look to it. And this is what we call angiofibroblastic tendinosis. And the reason why I mentioned this as a myth, as something that is actually not true, is although many people call it tendinitis, it's not strictly inflammation. It's not just inflammation that's happening. It's literally a change in the tissue quality. It's a grayish kind of edematous, friable tissue that changes over time, and that's really what hurts. If you think about the elbow, the lateral epicondylitis is this bone. Excuse me, the lateral epicondyle is this bone over here. And when you have tennis elbow, it relates to a specific tendon, the one that's called the ECRB. It's the extensor carpi radialis brevis tendon. So it's really that origin tucked away deep in here that causes pain. And what's interesting is a lot of people come in and say it not only hurts here, but it hurts down the arm. And the reason for that is the tendon literally extends into the arm and becomes a muscle. So that muscle, you can see some of it over here, but that's the root cause of this problem. Usually we start with something conservative. That's because most of the time it just goes away. And some of these options might be a brace, like a regular wrist brace. Sometimes it's a counterforce brace, which is a strap that goes around the elbow over here. Sometimes we use physical therapy, cortisone injections. Something newer that's very common is platelet-rich plasma, PRP. Very common way to treat this problem. Sometimes it works. It's not perfect, but sometimes it's a good option if you're thinking about this problem long-term. And other people have tried things like acupuncture. So there's a lot of different options on the table. These are the options I would talk you through if you came into the office, and it's something to try. I think some patients do great with some of these. Some people really get no relief. So I think that it's something we would talk through and spend some time figuring out what works best for you. If you think about cortisone, another myth that is really out there is cortisone can cure tennis elbow. And unfortunately, this is just not true. I think cortisone does have its place, but if you look at all the studies that we know of, and a meta-analysis is really a combination of many studies. If you look at the most recent data, basically cortisone doesn't necessarily cure it, but it can make it temporarily better. And it really has no extra benefit over other things like placebo. So I think that it's something to think about if you have a lot of pain and you really want some quick relief. But I say to most people that, we try to save it for really, if you ever need it, we don't use that as a first-line treatment. We know that the short-term results are good, but longer-term results, it might even be worse. So If you're if you're a professional tennis player, you might need it. I think that might help you get through your next tennis match or tournament. But otherwise, I probably would hold off on cortisone. Surgery never being helpful, is that true? That's also a myth. I do think that most data says you don't need surgery, but for those patients who have had pain for over a year, over 6 months, I think that's when surgery really can be considered. I don't think it's first line, but there are different ways that we do the surgery. So some of them are pretty non-invasive. If you have arthroscopic surgery, that's when we use a small camera, a small instrument that goes into your joint and it allows us to see the area that's the problem. We can address it by removing that painful tissue, that tissue that's friable, and we get rid of it. And sometimes even other things like a percutaneous release might be appropriate, or an open, more traditional type of tennis elbow surgery. So, these are options. I don't think there's much that we should talk about on this webinar, because I think as we move towards surgery, it's something that really is a personal choice, and it's may not be the right choice for you. So if you were to have this problem, tennis elbow, and you came to my office, we would kind of walk you through this and see if it's the right thing for you. Okay. So a couple take-home points just about tennis elbow. Tennis elbow is so common, we think of it as a part of life. It's not inflammation, it's not really tendonitis. You can even continue some activities because it's not a dangerous problem. You could think about cortisone sometimes in certain scenarios. Sometimes surgery could be appropriate. So all things to consider when you think about tennis elbow. All right, I'm going to take a quick pause and just check our Q&A. Looks like we don't have any extra questions, but I do want to remind our audience, if you have any questions, I'm happy to address them. Please do send them into the Q&A window that's going to be on the bottom of your screen. You can just click there, submit your questions, and I'll be checking on them to make sure I address all your questions. Okay, carpal tunnel syndrome, big topic in hand surgery, really, really common. But not everyone knows what it is. So carpal tunnel syndrome is actually a compression or pinching of your nerve. And there's a specific nerve in the hand that is pinched. It's called the median nerve. And the reason why it causes problems is if you pinch that nerve with this ligament that's inside and you get no relief, your nerve starts to fall asleep. So your hand literally feels like it's falling asleep, or you might get this kind of tingly or numbness feeling. And it's a problem because if this continues and it really doesn't go away, there's a picture here that I wanted to show you because it shows a small branch of this nerve and it goes to your muscle. So that nerve gets pinched and it's not relieved and is left really to progress. The muscle in your palm of your hand, especially around the bottom part of your thumb, can atrophy. And then you run into other problems like being able to grip or being able to move your thumb. So this is how it affects grip, and it's something to think about when you're thinking about how carpal tunnel syndrome can really affect your hands. Okay, so it's the most common neuropathy, compressive neuropathy. I think it's also the most common cause of days lost from work. So it's a big problem, and that's why it's so common as hand surgeons for us to see this. A lot of people lose time over from work for this problem, especially now more than ever when people are more on their computers at home. It's a real issue when you don't have the right appropriate ergonomics, and I'm going to get into that very soon. So risk factors, this is just what I was talking about. There are a range of things to consider, but I'm going to start with all the facts, the things that we know are proven that cause carpal tunnel syndrome. And then there's a few theories out there that maybe they're a risk factor, maybe they're not. And as you'll see through this list, there's a lot of things to consider. So for one, if you do any kind of high hand wrist repetition rate of any activity, like keyboarding, that can definitely cause this. I think if you have a high BMI, that's also known as a risk factor. And then there are all these things that kind of correlate. So computer work, any constant vibration can affect this. Any workplace forceful gripping. So if you're a carpenter, if you're doing something that really puts a lot of stress, a lot of grip force on that carpal tunnel, that can be a problem. Other things, rheumatoid arthritis can be an issue. I've seen a lot of people who garden a ton, especially during COVID. I think people who are outside doing a lot of work, this can be a real issue. And then tendonitis is also an issue. So assembly line workers, people who use their hands a lot, they develop tendonitis. This can squeeze that nerve and this can be a real problem. Okay, the things that are might be related that may or may not cause carpal tunnel or be associated with carpal tunnel are diabetes, perhaps your age, maybe affects some genders more than others, and drug use and smoking and race. So these are all kind of unproven, but might be on the spectrum of risk factors. All right, treatment. So I gave a talk a few years ago, and this was already really popular, but if you look on Amazon for carpal tunnel treatment, you'll find all these different types of treatment, including a magnetic wrist brace for not only carpal tunnel, but arthritis. So I think it's something that you're going to see a lot of advertisements for, but these are not, it's 475 reviews, and this was a few years ago. You can get it in rose gold, you can get it in black. But really what is known is there are three things that work for this. The first is a wrist splint, and it takes a couple months for this to really be effective. The second is cortisone, and that's something that helps because, again, it's a really powerful anti-inflammatory. So if you take away inflammation around the nerve, you can have improvement of your symptoms. And then finally, maybe some people could benefit from something called phonophoresis of NSAID, and that's really like Advil. But if you put enough Advil and it gets absorbed into your carpal tunnel, maybe it can help. And finally, really what I think is the third and most important is surgery. So surgery is something that we know works. It's something that is highly effective and very, very successful. Other things you really should ignore and really actively not participate in is magnet therapy. Some people try NSAIDs or even some kind of medications for nerve, and they really have been proven not to be effective. So if you are on gabapentin for this specific reason, it's something you should really consider to stop. And then finally, sometimes in a pinch, we will use something like prednisone, which is an oral steroid, but it's not a proven treatment, and it probably is going to be temporary. And of course, lasers, in this case at least, are not effective. Surgery is effective, and surgery can be done different ways. You can have an open traditional surgery, and that's when we use a small incision. This is probably not a great picture because I don't think anybody does incision this large anymore. But what you're doing is you're really cutting that ligament that is pinching the nerve. The other way to do this is endoscopic, and this is how I do 99.9% of my carpal tunnel releases, and that's with a small incision in the back of the hand. And what that does, it allows me to put in a small instrument that goes inside your carpal tunnel and cuts the ligament from the inside out. And the reason why this works so well is, you're away from the palm, you're not making an incision through the thick skin of your palm. And a lot of patients benefit from this because after surgery, people want to use their hands. And if you want to grip or hold something like a cane or a walker or play a sport or do anything that involves that gripping, this can be something that hurts a lot if you're healing your wound. So having an incision away from that area, more towards the wrist crease, can be helpful. Here's an example of a patient having that surgery. We use this special device. This is called an endoscope. That's why we call it endoscopic carpal tunnel surgery. It's a camera with this special instrument that goes inside and allows us to cut the ligament from the inside out. So you can see from this picture, there's no cut, there's no incision in the palm of the hand. It's really kind of far away from that through a small incision. Most of my incisions are probably 6, 7, 8 millimeters. If you look at the screen, the endoscope screen from my angle, as a surgeon, what you see is here. You have a nice shiny white carpal tunnel ligament. This is actually the root cause of the problem on the top of your screen. You have on the right side your actual nerve. So there's actually blood vessels that surround that nerve, and that's what we want to release and give more room. And then on the left side is some tendons. So we're inside the canal, and you're going to see on this video, I'm taking a look around, I'm evaluating what it looks like. And then we're advancing the camera, and I'm going to show you that some of these tendons actually move. So as I'm moving the fingers, you can actually see the tendons move. That's how we know we're in the right place, and that's how I know we can do what's next, which is the carpal tunnel release. And when you release the ligament, what we're doing is we're literally cutting that ligament. We're relieving the pressure on the nerve by using this knife that pushes and cuts. When you do that, you're creating more room in the carpal tunnel, and when you do it correctly, you have a nice gap on the top. And what that gap looks like is a wide gap from the left to the right of your screen, which literally creates more room. And you want more room with carpal tunnel release. That's the whole point. Outcomes for carpal tunnel release are great. Specifically for endoscopic carpal tunnel release, they found through pretty good high-level level 1 randomized trials that is less painful. They also have found that it returns people to work faster, so maybe about 9 days. And that could be, not that useful for some, but for some people that might be meaningful. They have also found that it's equally as effective as a traditional open surgery. They do think that it might be a faster return to grip strength. So that's an important factor for people who are really trying to get back to work or even just daily activities. It's definitely faster in terms of operative time, so that's great. That's less time under anesthesia. I think it's also less time spent in the operating room, which is always better for the patient. And finally, it's probably no difference in major complication rate. So after having thousands of patients have this type of surgery, when you compare the more traditional open with the endoscopic, there's really no difference in complication rate. So these are the reasons why I do almost all of my patients with endoscopic, unless there's some anatomic reason that I cannot. All right, so I'm going to move on to the last topic here. I like this one because it talks a little bit more about how concrete things you can do to help kind of prevent a lot of these problems. So Homoneuropathy is also known as something called cubital tunnel. And it's very similar to carpal tunnel because it's the same idea. It's a nerve pain, so it feels like it's kind of numbness and tingling in your hand, but it's not the same fingers that are affected. It's really your ring and small fingers that are affected because it's a different nerve. And when you have this problem, it can feel like it's numb, it can feel painful, it can be very tingly. Sometimes it wakes you up at night. And the reason why this happens is the nerve runs from your neck down to your arm and around the corner of your elbow. So it runs on the inside part of your elbow. And if you're like many people, like me, you're at home, you're on your iPad, or you're doing work, or you're holding your book. When you have your elbow flexed, when it's bent like this in these pictures, you're putting that nerve on stretch. And when the nerve is on stretch, it gets irritated and it feels like it's falling asleep. So this is a very, very common problem. People also happen to sleep with their arms bent, so that can also be an issue. So there are many different reasons for causing this, but the biomechanical, the physiologic reason why this happens is the nerve is pinched, and it's pinched in the location by the elbow. There are many ways to prevent it, but the idea here is you want to keep your elbows straight. So if you look at these women, whenever they are holding or using their keyboard, their elbows are a little straighter, and what they're doing is they're relaxing the tension. They're really taking the pressure off that nerve. So whatever change you need to do, I think that it's important to think about your elbows. You want to keep them less than 90 degrees. If you look at these photos, what's important is when you look at this woman, she's putting her elbow right on her desk. So is this person over here. And direct pressure is also a problem. So if you're really resting your elbows all the time on your desk, that can cause a problem. And the way to prevent that is you want to be sure that you think about letting your elbows hang off the table. This is a great ergonomic photo showing you how to adjust things like your monitor, like your elbow. Try not to keep them so bent. I think this is even a little too bent. 90 degrees is kind of a lot if you're really truly at 90. You do want to make sure your wrists are straight. That's going to affect not only neuropathy, but carpal tunnel. So that's something to think about. But it's important to think about all these things if you're working at home. This is a great example of a man here who has his elbows less than 90 degrees, so a little bit more straight. His wrists are straight. And all of this can help decompress and prevent Homoneuropathy and also carpal tunnel syndrome. So we've covered a lot of topics pretty quickly. It's 6:40 right now, so I think we spent a good amount of time kind of thinking about each of these problems. I'm going to summarize for you through each one of these. We talked really through one of the most common types of arthritis we see, which is thumb CMC arthritis. There are many treatment options before you even get to surgery. So I think it's important to make sure we really think through those. If you were to come in and see me, we would kind of walk you through and find the right one for you, which oftentimes might be a splint, and that's it. It might even be some cortisone shots, but we would kind of think through what is really the best option for you. And then if it comes down to it, if you do need surgery, we will look at your x-rays and think about what really is the right surgery for you. Trigger fingers, very common. This is a true inflammation around a tendon problem, so I think of it as a tendonitis. It can happen to any of your fingers. I think cortisone is really the most important and the mainstay of treatment for this. And if those cortisone shots don't work, in rare circumstances, we go to surgery. Tennis elbow, golfer's elbow, similar problems. I didn't really talk about golfer's elbow, but it's the same problem on the inside part of your elbow. This is something that can really affect your grip strength too. So I think learning how to prevent this, learning how to think through ways to avoid certain types of repetitive activities that trigger this are important. But if you get it, it's something that we think of as a rite of passage. So I think we can also think through options like cortisone or PRP, and maybe sometimes surgery, but sometimes all you need is physical therapy. A lot of times all you need is time. So those first three things can definitely affect your grip strength. And then the following two are really nerve problems, but nerves control muscles. So if you have severe carpal tunnel syndrome, that's going to affect your grip strength. If you have severe ulnar neuropathy, that will certainly affect your grip strength. So both of these compressive nerve problems, you can prevent them. In many circumstances, it's better ergonomics. For those people who have more than just moderate, maybe severe problems, you do want to be careful, because if it's not addressed, you don't want that atrophy that I showed you. You don't want that affecting your nerve endings, which connect to the muscles, which ultimately could be irreversible. So something to consider, something to be aware of, but certainly something treatable. All right, so I'm going to open up the floor to some questions. I think I answered many of them. I don't think I see too many, but here's one from Susan. This is a great one. What are ways to protect the wrist when doing yoga and Pilates? Yeah, this is something I get asked a lot. I think it's really important because, you know, I love yoga because I think it's really important for the body. I think it's a great way of doing exercise. But if you are doing something like a downward dog, your hands are on the ground and your wrists are kind of flexed. So when your hands are kind of in that position, you are really putting a lot of pressure on that carpal tunnel. So there are different things to think about. You're also putting some pressure on that bottom, that basal joint of your thumb. So when you are considering doing this, if you have pain, or let's say it's irritating your carpal tunnel, you probably need to adapt. So rather than doing that position, you may want to put your forearms on the ground instead. It may really mean that you have to adapt. But if it's something that really is not a problem for you and you're thinking about just how to protect your wrist, you can probably do all those things, because the benefit of yoga is probably outweighed by the risk of developing any of these things, especially if it's not a problem right now. So, you know, if you have specific questions about just like this, I think if you have pain that really affects that kind of activity like yoga or Pilates, that's a good reason to come in and just be sure we're not doing further damage. But by and large, I think most cases, there's not too much you have to do if you have no pain, if you have no symptoms. All right. Well, I do want to thank everyone for joining us tonight. I hope this has been helpful. I think that we are here to help you kind of think through these problems and really prevent these problems. So if you do need to reach us, we are available at Greenwich, Stanford, and Harrison offices. I only travel to Greenwich and Harrison, but I'm happy to see you all there. This is my personal email address. It's really not for urgent matters, but I'm happy to answer any questions. davidway.md@gmail.com, and I thank everyone for joining us. Take care, everyone, and have a good night.